More than 6,000 people take their own lives every year in the UK and Republic of Ireland. To prevent suicide, we need to know how many people die by suicide, when and where, so we know who is at risk. We need to understand how suicide data is generated, from how the cause of death is established through to what reported figures mean. When someone dies suddenly, the death is investigated. In England, Wales, Northern Ireland and Republic of Ireland, this is done by a coroner through an inquest, and in Scotland by a procurator fiscal through a fatal accident inquiry. The aim of both is to provide a verdict about the cause of death. But sometimes it can be difficult to establish whether the cause of death was suicide, which can result in deaths being misclassified. For example, in certain circumstances, a suicide might look like it was an accident rather than intentional, and so it might be recorded as an accidental death. Or there may not be enough evidence to say whether it was either accidental or a suicide. When there is not enough evidence, an open verdict can be given, or even a narrative verdict, where a description of the circumstances is given instead of a short-form verdict. Social or cultural factors may also influence verdicts. While suicide is no longer a criminal offence, ongoing stigma means suicide verdicts are sometimes less likely to be given, particularly if there are cultural or religious taboos around suicide, and even for the death of a child. Each of these factors can lead to the misclassification of suicides, which leads to underreporting. In each country, all deaths are officially registered. In Scotland, deaths are registered within 8 days. In the rest of the UK and Republic of Ireland, deaths are registered after an inquest. This means that there can sometimes be registration delays of a year or more. Delays in registration can prevent us from being able to respond to increases in suicide rates quickly. Once registered, information from death certificates is collated by the national statistical agencies in different nations. Here, all deaths are coded based on ICD coding rules provided by the World Health Organization, where cause of death verdicts are turned into codes. Short-form verdicts are easily coded in this way. Agencies can also code narrative verdicts as suicide if the description clearly shows that the person intended to take their own life. When this isn't clear, they are referred to as hard-to-code narrative verdicts. These are coded as accidental deaths. The use of hard-to-code narrative verdicts has been shown to have a real impact on our understanding of suicide. As the use of them increases, the use of suicide verdicts has decreased, which can make it seem like suicide rates are going down when they might not be. After coding, each agency calculates the total number of suicides. Suicides can be several different causes of death that tell us what physically happened and people's intent. Agencies combine these deaths to give the total number of suicides based on their definition. Different countries use different definitions of suicide. The UK's definition includes deaths where the underlying cause is intentional self-harm and events of undetermined intent. Including both helps to account for the problem of underreporting mentioned earlier. The Republic of Ireland's definition is different from the UK. It does not include deaths of undetermined intent, only deaths of intentional self-harm. This means they are adding up different things to get the total number of suicides. So data about suicide in the UK and Republic of Ireland are not necessarily comparable. Agencies also calculate suicide rates based on population data. This shows how many suicides there are per 100,000 people. This allows us to compare suicide rates between groups, as numbers can be misleading. For example, 2 places might have the same number of suicides, but if one has a smaller population, their suicide rate will be higher. But again, different countries' rates are not always comparable. Because of differences in processes and definitions, figures don't always mean exactly the same thing in different countries. So, the suicide rate in one country might mean something different to the rate in another. This means that it can be unhelpful to compare them. Instead, we can compare suicide trends between countries, considering increases or decreases over time. After calculating the number and rates of suicides, each agency makes them available by publishing them or providing them on request, just like they do for births and other deaths. They provide annual suicide data for the previous year. In the UK, routine data represents deaths that were registered in that year, but because of registration delays, some deaths may not have happened in that year. In Scotland, since deaths are registered within 8 days, data will mostly include deaths that happened in that year. In the Republic of Ireland, data represents when the death occurred, not when it was registered. Agencies provide data for males, females, and by age groups. Some also break it down further, for example by region. Other organisations also use the data and publish further detail. For example, Public Health England and the Scottish Public Health Observatory provide data by local authority. This is useful for understanding more about who dies by suicide and where they are. The journey to suicide data is complex, and there are some key challenges that still need to be addressed to improve the accuracy and consistency of data. However, suicide data is an important public health surveillance tool and gives us a powerful starting point to help us target our work and to prevent future suicides.